All right. So there are currently 25 million diabetics in the United States. They tend to have, this is a condition that is usually associated with complications and a high economic burden. It's actually found in a study by Fitzner that medical costs were 2.3 times higher in patients with diabetes than among patients that don't have diabetes. And this is largely due to sequelae of disease such as nephropathy, so problems with patients' kidneys that usually lead to expensive hemodialysis treatments. Also limb amputations, infections that don't clear. So these patients tend to have a high economic burden on the US. To avoid all these complications, patients traditionally have needed to have a lot of education on their diet and how to check their blood glucose. And traditionally, patients have gone to the point of care, so going to the doctor's office, talking to the doctor, providing their meal plans and their last couple of glucose checks, and having the doctor kind of give them pointers. But this travel to the point of care usually presents barriers. Patients have to take off of work, and they have to spend time at the doctor's office. They have to have all their information. And traditionally, diabetes patients are not the best at following up. So I examined telehealth methods, which are web-based systems, teleconferencing, and telephone communications. This allows the patient to upload their data to a portal and upload it directly to the doctor's office. The doctor is then able to provide real-time feedback on diet plans or how their blood glucose checks are going. So they're able to do that and give the patient pointers kind of as they go. This cuts down on travel to the point of care. It should cut down on they should have better glycemic control at this point and should cut down on the sequelae of disease that happen, and thereby lowering costs for everyone, just by giving them improved access to care. My PICO question was, in adult patients diagnosed with diabetes, does receiving care via telehealth methods as compared to traditional office visits improve glycemic control as measured by hemoglobin A1C levels? And I used hemoglobin A1C levels because they are an average of the last 3 months of the patient's glucose levels. The American Diabetes Association recommends that these hemoglobin A1C levels are less than 7% to avoid the sequelae like heart disease, stroke, blindness, kidney failure, and limb amputation. However, the CDC is finding that currently patients with hemoglobin A1C levels categorized in the poor territory, so higher than 9%, are found in 10% of diabetes patients. So in order to find out how these telehealth methods are currently doing for patients and their glycemic control, I did a literature search using CINAHL, PubMed, and Cochrane. Used the search terms telemedicine, diabetes, hemoglobin A1C, and glycosylated hemoglobin, which are the same, A1C and glycosylated hemoglobin. Searched in the last 5 years, picked out some of the bad apples, and found 24 articles. At the end, 8 were included. These were the ones that had telehealth methods that were congruent with what we needed to see, not just having people call on their phones, call their doctors on the phone, actually uploading data into portals or into online databases and receiving electronic information back from their doctors. And luckily, this yielded 2 meta-analyses, 3 random controlled trials, and 3 level 2 articles. I was very happy with that. This is just a quick summary of my results. I did use different populations. There was an article that yielded inner city African Americans, which was great. This population tends to have a higher percentage of diabetes. I used adults living in rural areas. Anything that kind of had congruent telehealth definitions I used. And overall, I found, at least in the highest level meta-analyses, overall we found that patients who utilized the telehealth methods actually did have better glycemic control. And those were statistically significant. So I was very happy to find it. So this did allow me to recommend that telehealth is used as an alternative method in diabetes management. It did show, kind of along in my research, I found that users cited that their reasons for not using telehealth methods, they were unaware that they existed at their doctor's office. They just kind of were going with what they had always done. And they were unsure and uncomfortable with the computer. So I wanted to recommend that telehealth is absolutely an alternative, but patients should be educated about the existence of the methods and how to use them. And providers should consider using these methods as a diabetes education. The research also showed that patients were most appreciative of web portals that were simple and easy to use, and they liked rapid feedback, as we tend to do. So I started thinking about a small practice that might try to implement, just a regular practice that might try to implement telehealth methods. Their barriers to implementation would be that it's a novel method, so it's not what people have done before. It's kind of uncomfortable. It's new for the patients. It's new for the staff who have to teach it. The staff will need resources for their own development, so they'll need how to actually teach. They'll need to learn how to teach. It's not always as simple as you'd think. And also the cost of implementation. So this would include contacting a company to implement to design the web service. Also, probably staff would need to be increased at that time since they'll be teaching, and they'll need more time to teach their patients. So cost will also be a barrier here. So to combat the patients kind of being unaware of the systems, we talked about promoting telehealth options to patients at every visit, kind of making it more comfortable, making it seen more than once. According to Cotter's change management theory, patients are more likely to make changes if they will benefit them. So I was thinking about how we would kind of convince patients that they would, if they had better glycemic control, how they'd be benefited. So if we concentrated on less time going to the doctor, fewer complications, and not overall the entire country's medical costs will go down, but your bills will go down if you're not going to the hospital to have treatment. So patients will understand how they'll be benefited if they participate in this. As far as staff training how to teach the patients to actually use the web portals, people learn in different ways. So staff should understand that some people need to take a handout and go home and mull it over. Some people need to do one-on-one computer time, and some people need to kind of read and practice on their own. So staff would be trained in different ways of teaching patients how to use these web portals. The teaching material should be in multiple languages. They're finding that specific patient populations tend to have higher diabetes prevalence, so provide the information in Spanish. They should concentrate on having computers actually at the center that can be used to learn the portals. And the staff will need to be trained on how to provide this feedback. So they'll need to learn how to actually communicate with their patients. And in order to combat cost, this is kind of a hard one. The research was indicative that telehealth would be beneficial. It would kind of be up to each practice, though, to determine how beneficial it would be. If the practice was able to determine if the money saved by treating its patients would outweigh the startup costs of actually implementing all of the research, perhaps by going through their files and finding out how many patients had these sequelae. So if they had 40 patients who were on dialysis, they had really expensive patients that they were treating all the time, and it would be less to actually buy these computers and train their staff. It might behoove them to go with the telehealth methods. So if it is if the positive effects do outweigh the costs, then they can go ahead and create the portals. It will be justified, and then perhaps even the increased staffing costs would be outweighed by patients who don't need to come into the office anymore, so they won't need as many staff members to see patients in the office. So that's about it for me. Any questions from you guys?
Thank you very much. We'll move into questions and answers now.
Sorry, I moderated. Hi. Oh, hold on. I'm not supposed to moderate. Yes, please. Do you have a question? Okay.
Karen does. Does studies say anything about how much, patient cost you as opposed to them coming into the office, like cost for? I know you're having a cost to create these portals, but because they're not coming in to see you, did they mention the cost they're losing by seeing them in the office?
By not seeing them? I think it would cut down on staffing costs. I don't know that it would. They would still almost have the doctor on retainer, so the doctor would still have to be providing them care. So no, I didn't.
They charge for this telehealth? That's what I'm asking.
I think I didn't actually see that in my research, but I would imagine they do, since they're still providing care.
Right.
But not. Hi.
Do you have a question? I do.
About
compliance, like patients been compliant?
it's terrible.
Yeah.
Compliance is terrible. I mean,
I read a little bit about that, and this is like one of the major issues, compliance.
and I'm one of those head in the sky. This sounds so great, but compliance. If you're going to be non-compliant with your diabetes care at home, in the office, and non-compliant with going to see your doctor at the office, you're going to be just as non-compliant. It hurts my heart to say, but it's absolutely it was terrible either way.
Did you see if any particular type of medicine helps somebody be less compliant than another?
Be more more.
Yeah.
Be more as long as it was simple. So it really said that in the studies that I read, if people had good attitudes about diabetes care beforehand, they'd have good attitudes about it afterward. A lot of this was selection bias. Anyone who would participate in this was already wanting to be compliant. So it makes sense.
Did you look at type 1 and type 2 or only type 2?
That's a good question. Actually, a few of the studies looked at type 1 as well. Most of it, they were trying to reduce noncompliance in type 2, though. And a lot of the studies, some of the exclusion criteria were anyone who was already on insulin, they would be excluded. Most of the studies did.
I would think that a younger population, they may be more likely to use telemedicine because they already are digital natives.
Right.
If they're younger.
No, you're totally right. That's why they excluded them from a lot of the studies, I think.
Did you find anything in the literature that looked at the psychosocial implications of using telemedicine, in the sense that, they're receiving healthcare management and test results, not face-to-face?
I mean, they seem to really like it, but it was the study said if they already had good feelings about the internet and they already had good feelings about diabetes care, then they would continue to have good feelings about it. That was this one really cool study. It was all psychosocial. I was actually predicting whether people would want to use it at all. So it was really, if people are going to be good at it, they're going to be good at it, and if they're not going to care.
In your research, did any privacy issues come up with using telehealth for communication through a phone or
Through
a portal?
So the portal, there was a study that talked about that, that talked about the HIPAA violation possibilities. And actually, one of them, I think the Chen study, had a problem with it during their study. That's actually a really, really good question. They had a problem with it during their study because it was longitudinal. And after a while, they realized that it wasn't coded correctly. So that was a whole conversation under the conflict of interest part. So yeah, it's definitely another concern.
Any other questions? Thank you very much.
Thank you.